Hello, everyone, and thank you for joining us today for today's webinar, Recommendations and Collaborative Strategies for Systems and Organizations Working at the Intersections of Domestic Violence, Mental Health, and Substance Use, hosted by the U.S. Department of Health and Human Services, Administration for Children and Families, and Substance Abuse and Mental Health Services Administration, and the National Center on Domestic Violence, Trauma, and Mental Health. My name is Gabriela Zapata Alma, and I'm the Director of Policy and Practice for Domestic Violence and Substance Use with the National Center on Domestic Violence, Trauma, and Mental Health. Today's presenters are Kenya Fairley, Supervisory Program Specialist, Division of Family Violence Prevention and Services, Family and Youth Services Bureau, Administration on Children, Youth, and Families from the Administration for Children and Families with the U.S. Department of Health and Human Services. Dr. Justine Larson, Senior Medical Advisor, Center for Mental Health Services, Substance Abuse and Mental Health Services Administration with the U.S. Department of Health and Human Services. Dr. Carol Warshaw, Director, National Center on Domestic Violence, Trauma, and Mental Health. Lori Morton, Advocacy Initiatives Director from the Alaska Network on Domestic Violence and Sexual Assault. And Regina Rooney, Education Communications Director from the Maine Coalition to End Domestic Violence, as well as myself. Before we get started, I'd like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using this Webinar System tab in the center of your screen. You can switch to this screen from the slides by clicking the down arrow next to Using this Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right hand of the screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud icon at the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Carla Alegria, also with the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options. But for this session, you'll want to select all participants if you would like to respond to a question from the trainer or to contact center staff anytime during the session. You should click on Carla Alegria to privately contact her if you are in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, type in where you're calling from, and then press Enter? Perfect. Thank you all very much. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the arrow next to where it says Chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a Media Viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. We've planned time for questions and answers towards the end of this webinar. At the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to an internet connection, so feel free to call back if that becomes a problem. If you're experiencing technical difficulties and are unable to contact Carla, you may call WebEx Tech Support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. Again, thank you for joining us today. Here is our welcome and agenda for today, and I will now turn it over to Dr. Larson.
Hi, I'd like to welcome everybody to the webinar. I am the Senior Medical Advisor at the Substance Abuse Mental Health Services Administration. The mission of SAMHSA is to reduce the impact of mental health and substance use disorders on America and American communities. And so at SAMHSA, we're interested in this ongoing work. We recognize that there is a significant overlap between individuals who have experienced trauma and or domestic violence and individuals with mental health and substance use disorders. Thank you so much for your interest in the subject, and we are looking forward to hearing more from this webinar. Thanks so much. Now I'd like to pass it to my colleague at the Administration for Children and Families, Kenya Farley.
Hi, everyone. Welcome to the webinar this afternoon. We are really excited to have you all join us today. And I'd also like to send greetings from the Director of the Family Violence Prevention and Services Program, Shondell Dawson. Unfortunately, she was not able to join us this afternoon due to other competing webinars that we're hosting here within FISB, but she sends her regards. And she's also really excited that we're continuing to push out this information around the intersections of substance use and intimate partner violence. We've been working with our colleagues at SAMHSA as well as at the National Center on Domestic Violence, Trauma, and Mental Health for the past couple of years to really think about how we can send out information, additional resources and materials, as well as guidance on partnerships at the local and state levels to really create change for survivors of intimate partner violence who also may need additional services and supports related to substance use treatment or to mental health services. So you'll hear a great deal of information today on this webinar, not only from the National Center and the wonderful technical assistance and training that they're providing, as well as a lot of great research that they're doing, but you'll also hear from some of our colleagues who are working at the state level about the integrated services and some amazing work that they're doing to really strive to meet the needs of survivors. So you're going to hear a lot about that today on this webinar. We certainly encourage you to stay in touch and to continue to reach out when you have questions or technical assistance needs. If you go to the next slide, I'll just give a quick overview of the Joint Information Memorandum that we put out in this past year with SAMHSA. So as you all know, there are many overlapping and interrelated issues when it comes to thinking about the needs of survivors of domestic violence, substance use, and mental health. We know that this impacts large numbers of people across the United States and that the consequences can be significant and ongoing. We also know that people who use abuse tend to target a person's mental health as well as their use of substances in order to continue to further abuse, cause harm, as well as try to manipulate the systems in which they go to seek out help. So historically, these issues have been addressed in silos, and what we're hoping to do now as we're continuing this work is to really bridge the gaps between these issues and also bridge the gaps between service systems so that the work and the response for recovery and safety for survivors can be much more intentional, thoughtful, and really much more responsive to the complex needs that survivors have. So we're hoping that as we continue to distribute this information and work with you all at the state and local level, that we can really find ways to address the existing policy and research gaps, as well as find and promote those promising emerging practices that are really effective. So on this next slide, you'll see that when you have an opportunity to read through the information memo, that we really are trying to address these critical intersections between research and services and practices, and that with the information memo, when you read through it, you will have additional resources that are provided and some recommendations for state and local providers and service systems. So on this next slide, you'll see links to the information memo as well as a partner's guide, which I'm sure our colleagues at the National Center on Domestic Violence, Trauma, and Mental Health will talk a little bit more about. So I'm going to pass it over now back to Gabriella and Dr. Carol Warshaw to really talk about the great work that they do at the National Center on DV, Trauma, and Mental Health to address these issues.
Great. Thank you so much, Kenya. And so what we're hoping to share about today are some of the strategies that state mental health and substance use disorder treatment directors, as well as state FIPS administrators, could implement in their states. And we have two fabulous presenters from Alaska and Maine who will also walk us through the great work that they're doing in their states. And so taking a high-level view, here are some of the different ways that folks can collaborate, that partnerships can be developed. cross-training and encouraging training across systems so that all of our systems can become more responsive to survivors and their children when they're experiencing substance use and mental health. And that in part of this also includes establishing linkages so that we can have, we can safely link survivors as well as have rapid responses because we know that when there is ongoing targeting and abuse, that time is really of the essence, and that there are safety needs that need to be, that survivors need support with and need help accessing the resources that they identify as needing. And so all of this also includes supporting integrated approaches. So being able to take a no wrong door approach that rather than getting bounced between systems, the survivor and their children, when they have children, can seek help, and that wherever they seek services within the different systems, that there's no wrong door, and that they're welcomed and entered, and they have access into that system, and then can be linked and connected with any other services that they identify needing. And so, thinking about different ways that we can support cross-sector collaboration. And these additional strategies are from several of the national surveys that we've conducted recently, and Carol towards the end will provide more information on that, as well as key informant interviews. And so understanding that, that this kind of collaboration and integration does require support, and thinking about ways that we can incentivize this cross-sector collaboration. And so looking creatively where we are and what kinds of incentives and supports would be most tailored for our system, but in some cases looking at potentially licensing of professional providers and licensing of service sites, being able to support collaboration through licensing and certification, and as well as funding requirements or joint funding and funding incentives. Being able to establish specialized work groups or task groups that can look at the needs within a specific community, as well as what are the opportunities and the resources and the strengths, in order to make a really a tailored plan that is responsive to the needs of your provider groups and your community members. Legislative initiatives and statutes at the state level, interagency policy development, and federal policy guidance to states. So what are some of the ways that this can work? And here I'm going to turn it over to Lori Morton and Regina Rooney after introducing them. So Lori Morton is the Advocacy Initiatives Director from the Alaska Network on Domestic Violence and Sexual Assault. Lori started work in the battered women's movement in 1984 in a rural East Texas shelter serving 9 counties. In 1989, she moved to Bethel, Alaska, and served as the director of Tundra Women's Coalition for 5 winters. She served as director of Alaska's coalition for 10 years and served at the State Council on Domestic Violence and Sexual Assault for 9 years. She worked for Alaska's Division of Behavioral Health for 2 years and is back at the coalition, where she serves as the Advocacy Initiatives Director. And Regina Rooney is the Education Communications Director for the Maine Coalition to End Domestic Violence, where she has worked to bring prevention and awareness strategies to stakeholders throughout Maine since 2013. Her work includes collaborating with and providing training for employers, healthcare workers, educators, advocates, and the general community, with a focus on changing the social conditions that allow abuse to go unchecked and perpetrators to remain invisible. She came to the domestic violence movement in 2008 when she began volunteering on the helpline at her local domestic violence resource center, and her pronouns are she, her, hers. And so now I will turn it over to Lori.
Thank you. I'm happy to be here today. A common way to introduce yourself in Alaska is to say your name and to say the kinships behind you so that you can find common ground to better interact with the people that you're connecting to. So I'd like to let you know that my English name is Laurie Beth. Laurie from the Greek laurel and victorious spirit, and Beth from the Hebrew Beth-El, which is the abiding place of God. My Yupik name is Menikik, which when you are going down a river in a boat, as the boat propels forward, the motor has this white churning water behind it that ripples out onto the shore. And as those ripples continue to lap up against the shoreline changes. And that is mostly what I feel like most of the time, not necessarily a victorious spirit, although every day in the work we certainly have opportunities to celebrate the good things that happen, but more like this constant affecting, evolving change of our community and our Alaskan landscape, because one day we are not going to have violence against women. Instead of letting you know my kinship in terms of my parents and grandparents, which probably wouldn't help us find some common ground, I want to let you know of some women who have inspired me in my early work and whose names may be familiar to some of you in the domestic violence and sexual assault movement. Women like Barbara Hart, who inspired us to learn more and dig in about legal issues and confidentiality and working for the rights of women. Marie Fortune with the Faith Trust Institute. Diane Smalley from Michigan, who is a Presbyterian minister that worked with women in prisons. Anne Menard, who I knew when she was with the Connecticut Coalition, now with the National Resource Center. And Mary Pete, which you probably don't know unless you're from Alaska, but she was one of the original Yupik women researchers on violence against Native women in Alaska. Next slide. If you look at Alaska, you see that big number, how many square miles we have and how much coastline we have. I think the important thing to focus on is that last sentence. Less than 10% of the state has road service. And that road service is mostly from where you see the small town of Seward up in that south central area of the state. So that means if you need help, you cannot get in your car and go anywhere else for safety. You are in your community until you can boat out or until you can fly out. Our weather affects very much whether people can fly out or not. The winter is much more difficult than the summer. So when you think about providing service, that's something that's always in the forefront of our mind. And the other thing about Alaska and its vastness is the way in which communities formed, villages formed. We have 229 recognized tribes in Alaska, and language groups. There are 20 different Alaska Native languages. There are 90 languages spoken in the Anchorage School District. And with people speaking all these languages, their culture is involved, and ways in which we communicate to each other is challenging at times. Next slide. Which led us to try to look at ways where systems could better work together so that once you've navigated the airway and you've gotten to a safe place, once you've found somebody who speaks the language you speak, once you have gotten yourself into a place where maybe help is more easily accessible, you then don't have to go through the difficulty of looking at the domestic violence program in one corner, looking at the substance abuse disorders help in another corner, going then across town to mental health. How can we have an only right door policy so no matter where you go for help, you can get that help? So one of the things we did was apply for a rural grant, and we're successful at getting that. And we are looking at 3 communities, Nome, Kodiak, and Ketchikan. And don't take the slides back, but just if you think back to our map, Nome is in the northwest section of the state. Kodiak is in south central. It's a separate island off of the mainland. And Ketchikan is down in southeast Alaska. So we have a diversity of communities, language groups, ways in which people interact, but they have these 3 parts of the system that need to work well together so that they can service the people who need that help. An additional partner that was really important to us was tribes. And so each community, in addition to the domestic violence sexual assault program, the substance use disorder service providers and mental health programs have tribes involved in their planning committee for this exercise. Another person who is close to my heart that many of you will recognize, her name is Patty Bland. Patty worked with us in Alaska for several years, bringing her passion for advocacy and working with domestic violence survivors, and combining that with those who also had substance use disorders. In her development of real tools, she worked with the Iowa Coalition, and Megan Jones is also on the call at the end of our time if there might be questions, or if you want to know about Iowa's experience, you can certainly contact Megan. It was a way in which you could best support survivors, that you really needed to look at the ways these programs were interacting and interfacing with each other, and how to have seamless service delivery. So what we're doing is ensuring that cross-training goes on between the local programs. So domestic violence and sexual assault staff are training substance use disorder staff, and vice versa. And what does it mean? What are our services? What can we offer? How do we interact with people who come to us seeking those services? We're having training where the network staff and a health consortium, the Alaska Native Tribal Health Consortium, goes out and works with the communities, providing advanced training, thinking through legal issues, confidentiality, what does it mean to provide an integrated service, what does that look like? And then we're going to have a year where the communities have chosen their integrated service and are implementing it. We have high hopes for this grant and want to have it come together in such a way that then we can replicate it throughout the state. So we can pick 3 more communities to start on that journey and then continue in supporting them. Next slide. It's also important not to look at the intervention only, but at prevention. So how can we support communities in creating atmospheres where domestic violence and sexual assault is not the norm, where substance use disorders are few and far between, where people's mental health takes priority. And for a while, the domestic violence sexual assault programs had an individual prevention track, and behavioral health, substance use disorders, suicide prevention had another track. And we were asked, the state was asking local communities to do both of those things separately. So one of the things we've really worked on is integrating those community coalitions so that I, in my DV hat, don't have to go over to some other place and put on my substance use disorder hat, but we can all meet together to look at that, how we can help prevention. What are complementary messages? How can we continue at the local level to work with the state so that those individual state departments see the importance of combining efforts? And how do we look at prevention as a whole? So what will your statewide prevention plan look like? If you could go to the next slide. So building on pockets of hope and healing, there are some things that are happening in individual communities across the state that I supported in early work with the Council on Domestic Violence and Sexual Assault, and that communities, particularly in rural, remote areas, were working on. So one of them is fairly simple, the 10 free counseling sessions for victims and survivors. If you are in a regional program and in that village or small community, there is also a mental health provider who has been through Domestic Violence 101 and trauma-informed counseling, which is something that we have a state training program that provides for mental health workers. Then the victim survivors seeking services at the shelter can have 10 free counseling sessions. It's not something that everybody needs, but it's so nice that we have that available. There's also something called SISTER, Safety and Sobriety Through Recovery Program. And that's where both single women or women with children who may have barriers because they need child care can access a substance use disorder program while they're staying in the shelter. And this is something that came out of a program in Dillingham, Alaska. So if you think back to the map, that's in the lower southwest portion of our state. And they have on-site substance abuse counselors that provide outpatient services and access to other agencies as needed. The advocates help with safety planning. There's child care on site so that the women can go to intensive outpatient treatment. And it's really a way in which we can support women's safety for maybe their domestic violence, sexual assault issues, and provide space and time for them to look at what treatment may be for them or how to help them with substance use disorders. One of the things we are excited about starting are what we're calling joint association calls. And the Network on Domestic Violence and Sexual Assault is a member organization. We have 24 member programs. There is also an association of behavioral health advocates in Alaska called ABHA, and we are going to work together to have those two groups have some joint association calls. So at a more broad level, we can look at how can we better work together in integrating our services. So it's at the local level, the regional level, and the statewide level, and I think my time is up. So I will hand it off to Regina, who is with the Maine Coalition.
Awesome. Thank you so much, Lori, and thank you all for having me. Can we go to the next slide, please? So I'm going to talk a little bit about this journey we've been on here in the state of Maine towards improving the response of mental health providers to both survivors and perpetrators of domestic abuse. That has taken the shape for us in the form of a statewide training requirement for licensed mental health providers. So I'm going to talk sort of about where we've been, where we are now, and where we're going, and offer some reflections on that process. Next slide, please. So I would start by just saying that Maine is a really great place to be. It's a wonderful state. We're the largest New England state, which still feels really, which feels very in perspective coming after Alaska. And we're a largely rural state with some pockets of more populous areas. And while we're known for being a pretty safe place, it's not really so for people who are experiencing abuse, obviously, and domestic violence accounts for about half of our homicides each year, and that has been a pattern for quite a few years. NCDV has 9 member programs serving the entire state, and we work alongside the Wabanaki Women's Coalition, which serves Maine's 5 tribal communities with domestic violence and sexual assault advocacy, and our partners at the Maine Coalition Against Sexual Assault. So how did we sort of, with that context, get to where we are? It's a long story, but the short version is that advocates have been hearing for years troubling stories about survivors' experiences with therapy and counseling. And then additionally, those advocates who are also licensed have talked about their experiences in school, that their programs reflected a fundamental lack of understanding about domestic abuse and violence when they included any information about it at all. Between the years of 2006 and 2010, an advocate from one of our local programs named Ellen Ridley worked with a professor at the University of New England, Amy Koha, whose work focuses on intimate partner violence, to explore this question: how do mental health counselors enhance or compromise the physical and emotional safety of domestic violence victim survivors by their counseling practices? So the study really helped quantify that sort of anecdotal evidence that we've been hearing for years. So 75% of the respondents to the study were in severe to extreme danger of being killed, according to the danger assessment that they did as part of the intake for the study. And yet less than a quarter of counselors were actually conducting written screening. Only about half of them were conducting verbal screening. Only about half of them were helping those survivors plan for safety. And you know, there was a lot of information about the harm that was being done. It also, however, really illuminated what was helpful to those survivors. It was helpful when their counselor had an understanding of the dynamics of domestic violence, when they were empathetic and supportive, when they identified the survivor's strengths, when they told the survivor that the abuse wasn't their fault, they assigned responsibility for that appropriately, when they helped them plan for safety, and when they connected them with local domestic violence resources. So the good thing about this study is not only did it help illuminate some of the harms, but it really pointed to what is going to be really useful for survivors in Maine, and that is not rocket science, right? At the same time that the study was going on, Maine's Domestic Violence Homicide Review Panel was highlighting again and again in their biannual report opportunities for intervention that were being missed by licensed providers, particularly around the link between perpetrator suicidality and homicide. And in 2012, they formally recommended that the state require training for licensed clinicians in domestic violence. So following that recommendation, in 2013, the Maine legislature ended up passing LD 1238, an act to improve professional training for licensed mental health clinicians. And this legislation followed models offered by California, New York, and Florida. We certainly didn't invent this wheel. but it really rested on that groundwork of the Maine-based information from the review panel and from the study by Amy Koha and Ellen Ridley. Many of the folks involved in those efforts testified in favor of the requirement. So it was really a great example of getting this evidence base and then bringing it forward. This was before my time at the coalition, so I want to recognize the work of our then director, Julia Colpitts, in this effort. And the requirement as passed states that starting in 2020, so as of this year, all licensed social workers and counselors must demonstrate 12 hours of training, and psychologists must demonstrate 3, either when they apply for their initial license or relicensure, and that is a one-time requirement. So from there, we moved into the implementation phase. And obviously at NCDV, we offer a range of trainings that could count towards this requirement, but we really wanted to create a single curriculum that was focused on this audience of people that could be used throughout the state, throughout our membership with our partners, both to ensure consistent messaging and for efficiency of resource. Like, why on earth would we all create separate things to meet this same requirement? So to do that, we convened a multidisciplinary advisory group that included survivors, advocates from both our programs and the Wabanaki Women's Coalition, and colleagues from various mental health licensures so that we could build a culturally relevant, trauma-responsive, and survivor-informed curriculum. All those words, right? But it was really important. So we worked on that through 2016 and 2017. NCDV played the role of bringing together the information and actually doing the work of compiling the ideas and the case studies and all the information that people were bringing together. And honestly, it stalled out a bit there due to lack of capacity. It was a much bigger project than I could carry forward. And so process-wise, we ended up hiring a consultant with whom we'd worked previously to help pull those threads together and actually create the curriculum. And that was a really key decision for us to invest that resource in that way. It's also worth noting how prominently we feature resources from the National Center in the curriculum. Their work has been so helpful, and we've really been lifting that up in Maine. So once we were about sort of wrapping up that development process, we wanted to seek approval via the licensure boards because we wanted to be really clear that the training we offered would satisfy the requirement in the eyes of those boards. We wanted to be able to really say that with confidence through our trainees, and so it did take some additional time to get clarity. We were dealing with 3 different boards for social work, counseling, and psychology. And while we were really eager to iron out those nitty-gritty details, and we were fielding questions at the coalition from as early as 2017 about this requirement and what would count from people's past, et cetera, the boards had very full agendas and were not in the space of really digging in at that time. And so eventually we ended up connecting with a person who oversees all 3 of the boards, which I think was a really helpful thing in terms of securing the kind of approval from all 3 of them. Next slide, please. So where we are today is really about doing the training. We're just doing the training. It's 2020. It's the year. The curriculum is being offered by our members, by our coalition staff, and by our partners at the Wabanaki Women's Coalition. One of the things that we realized pretty quickly was that we needed at the coalition office to think about staffing this effort differently. Because so many people who currently hold licenses need to meet the requirement this year, we were literally flooded with training requests starting in early 2019. And we had to put in place some structures so that we could field all those requests smoothly, compile trainings from across the state into one place so people could find out what was happening in their local areas, show up and train in the room for people, and also offer the TA needed by the membership while they were dealing with that same kind of influx at the local level. Next slide, please. So this quote is pretty typical of the responses we're getting to our evaluations, which is good news. And because certainly we want what we're doing to be relevant. And really excitingly, we're working with Dr. Elizabeth Armstrong from the UMaine School of Social Work to evaluate our training, which is going to give us a much more robust sense of the outcomes than these post-session evals do. Her study is designed to explore how trainees' beliefs and practices change over time. Next slide, please. So we have a whole list of things that are still on our list that we need to get to, but I guess I would focus on we're very much interested in thinking about how we can step into creating ongoing learning opportunities for licensed folks that sort of go beyond the core competency that this training is designed to establish. And then also we know that eventually people who are applying for initial licensure will really be the people mostly who are needing training. So how do we integrate training into the academic programs in Maine so that folks are having that when they come out, and also raise the bar around instructor knowledge of domestic abuse and violence? Next slide, please. So really quickly, I want to, with the rest of my time, just talk briefly about lessons learned. One of the big things was that the state level data really mattered. It wasn't like it was all new news to those of us working in the field, but it did really have an important impact on the legislative process to be able to bring that state information forward. And it also seems to impact the trainees in a way that national level data does not. The second piece here about time, I can be humble and say I had no idea how many layers going in we would need to peel back to really do this project. And the organizational investment in having our consultant Claire come in to help with the actual creation of the curriculum was key. Allocating additional staff resource to the effort has been key. We're really fortunate to have such buy-in for this effort at our coalition and throughout the state, but that was really, really important. It was much bigger than something that was like a project that one or two people could take on. It became really clear to us, or it has become clear to us, that our trainees have had little opportunity to think about and learn about people who are doing the harm. So our statutory language actually includes both, I'm going to use my air quotes here, victims and perpetrators. And that's no accident. It's how we're going to get to the heart of the patterns identified over years in the Homicide Review Panel reports. So we might not have all the answers about that, but we're opening space up for the conversation, and it's happening at the same time that Maine is attending in new and focused ways to the quality of service in our batterer intervention programs. So the timing is really good for these conversations. And then, you know, I am really grateful. I think it's worth spending time to identify the right partners if you're going to take on this kind of project. I'm so grateful for the folks on our advisory board, because while we recognize the best practice is co-presenting with a licensed mental health providers, that isn't always possible. So when we have a team of 2 advocate trainers, and we always train this curriculum with 2 people, it is 12 hours, it is a lot. When we have a team of 2 advocate trainers, we can lean on the credibility and expertise of those licensed folks who help develop the training to help say, really, this is relevant from folks in your field. And then the last piece I would say here is that this isn't so much a lesson learned as much as a reminder that if the rules and regulations and administrative practices and theories that guide people in their work don't change, then increased education alone isn't going to do it. And so we're well aware of that. And this training has been a really wonderful opportunity for us to strengthen the bridges. I mean, it's definitely not a one-way NCDV sort of pushing information out. It's been very much a two-way dialogue. And we have learned a lot about what else we might need to shift in order to create lasting systems change in our state. Last slide, please. And that's just my contact information. There's a lot more detail I can share if you're interested in, or if your state is pursuing something like this. Thank you for the opportunity to share. And I'm going to pass it back to Dr. Warshaw.
And thanks, Lori, for your really wonderful and thoughtful presentations. There's so many things. I'm going to talk a little bit about what we're hearing from survivors and from the DV and mental health and substance use treatment fields from some surveys that we've conducted and interviews we've conducted and from the work we've been doing. But I also wanted to highlight before doing that the importance, part of what, we talked about in the information memo was, talking about state level collaboration with state mental health and substance use disorder treatment directors and state FIPS administrators. But what we're hearing about is many other types of potential state-level collaborations and also local and community-level collaborations. Lori, that you were able to talk about 3 communities that were doing wonderful work on multiple levels of really thinking about what do survivors need and what can we do to make sure there's no wrong door. And then when you were working at the state as a state administrator, thinking about the partnerships you were able to have with the state mental health folks and the different kinds of things that can come from those relationships. And a lot of it is about relationship building over time. And for Regina, we were so excited to hear that you were able to do this. And one of the things that's been an issue is, do you want to require training on domestic violence for licensing requirements? And I'll talk about that in a minute, some of the data from surveys. And, is that a barrier of people, is that off-putting to people? And I know in our conversations, and maybe you can talk about this more in the questions, that people, there are always some people who don't want to do this, but mostly people who thought they knew what they were doing, realized how much they didn't know, and were actually grateful and appreciative. So I think just listening to what it takes in the long process to create legislation and then to do this really well and build the partnerships, I think is something that we can all learn from. So next slide. So I'm going to just talk briefly about, and I'm going to be mindful of the time, so I may go through this more quickly. 3 national surveys that we've done over the years at the National Center. The first one was actually the middle one here, the NASHPD, National Association of State Mental Health Program Directors, that we partnered with to survey 43 state mental health program directors or their designees. And this is in 2012. And the other 2 we did in the last year in 2019, the study of 527 local and tribal DV programs that we're writing up now, and a survey with the National Association of State Alcohol and Drug Abuse Directors of 26 state substance use disorder treatment system administrators who, for the most part, were women's services coordinators. And for those of you who aren't familiar, the SAMHSA substance abuse block grants have a carve-out for women's services. The mental health block grants don't. And the women's services coordinators are often very attuned to women issues impacting women who are using substances and accessing substance use disorder treatment. So sometimes more tuned to issues related to domestic violence. But what we found across all of these surveys was there was a high level of need that all of this, both the DV field and mental health and substance use disorder treatment field, were recognizing that there was limited collaboration across sectors. In the NASHPD survey, 17 of the 38 states said there were state-level collaborations. 9 said there were actual real policies in place, and 3 said there was programs in place to provide rapid access for DV survivors to mental health services. And in the NASADAD survey, 24% said they had solid collaborations, 28% limited, and 32% said they really wanted them. We also found that there are multiple barriers to effective collaboration, and I'll talk about them in a few minutes. But there was what was most telling was that there was a high desire for cross-training to access to collaborative or integrated services, a continuum of services, but to ensure that survivors had the range of services that they need, and efforts to address system barriers. So next slide, please. So the first study I want to talk about is the DV Programs Needs Assessment Survey that was conducted between June and September this past year. And we contacted state, territory, and tribal nations, and there were 527 programs that responded. And they were asked about their needs and their capacity related to substance use and mental health, and what kinds of things and recommendations they thought were important, and also about their successes. Next slide, please. So for the substance use part of the survey, you can see that 69% of the programs who responded said that they were hoping for more expedited referrals for substance use disorder treatment. And we know that from talking to programs across the country that access to services for survivors in their programs is a huge issue, particularly for programs in rural areas. And that's often a state policy issue that is needed to address barriers to care for survivors. Another high-level need was training for staff on the intersection of domestic violence, trauma, and substance use. And then the next one was for funding for more on-site substance use disorder services. And you can see some of the others are cross-training partnerships, guidance from successful programs, and co-located addiction specialists. So there are lots of needs, and they have to do with really access to treatment. Next slide. Some of the actual successes that programs talked about were, on the flip side, were collaboration with substance use disorder treatment providers, being able to hire substance use counselors on staff, partnering with substance use programs to provide a counselor on site in the DV program. So there's being able to have really good collaborative referral relationships, being able to provide on-site services, and taking harm reduction approach so that survivors could be served regardless of whether they were using substances or not. Often housing first concepts as well. Some were able to use funds from an OVW grant to provide services in transitional housing programs, and others could use VOCA funds to provide services off-site with counselors. Similar findings around mental health-related needs. 77% said they really needed expedited referrals for mental health treatment. Again, access to treatment is huge, and access to treatment with providers who actually understand domestic violence and trauma is really critical, and that's part of why the work that both of you are doing is so important. Training for staff and funding for more on-site services. And again, that speaks to when we're talking to state-level administrators, how are we using our funding, and is it available for hiring on-site services, for putting in the time that's needed to build collaborative relationships, and to increase access to mental health and substance use services across the state. Next slide. The third study was the survey of the NCDVTMH survey. And again, that's the partnership with us and NCDVTMH that was conducted this summer, spring and summer, May through August of 2019. And we representatives from 26 states and territories responded. Next slide, please. And part of what we're talking about now is the qualitative data and the suggestions that respondents offered for improving service delivery and for improving state, territory, and federal responses. So one of the things that people talked about was increasing access to co-located and integrated services. So what we're seeing is that this is coming both from substance use disorder treatment state administrators and providers, as well as from DV providers. And in recent literature we did some large-scale surveys of substance use treatment providers across the country found that NDV programs who were doing some kind of collaborative integrated services. On the DV side, they were more likely to provide services that were in collaboration with a substance use disorder treatment program. And on the substance use disorder treatment side, they were more likely to have on-site DV services. So another thing that people talked a lot was decreasing barriers. And in this survey, people talked about transportation to treatment on demand, and that was a huge issue for DV survivors. And we know when we talk about substance use coercion that abusive partners often actively prevent their partners from being able to engage in services. Child care is also a huge issue, so having services that either provide child care or provide two-generation services is critical, and training. But some of the other policy related suggestions included requirements and funding and the suggestions that came from this survey focused on screening and treatment or cross-training. Next slide, please. So some of the things that people talked about were wanting to have interagency policies at the state level, but also at the local level to provide more effective services for survivors of DV. And those of you who have worked in doing collaborative initiatives in your states or communities know that that relationship building takes a long time to understand the barriers, to understand the ways each set of service providers thinks about these issues, to make sure that safety issues are and confidentiality and mandated reporting requirements are all attended to. Part of what people talked about was putting requirements written into FOAs and to really think through what those would be. And other respondents said, don't just put them in grants, put them in rules and regulations, because that will have a lot more clout and be a lot more effective. So part of what that means for those of you who are working at the state level, who are advocates, trying to impact what's happening at the state level, is thinking about where there are opportunities to incorporate something into your state requirements. And another layer of this was thinking about language incorporated into state contracts and licensing requirements for programs who have state contracts, as well as licensing requirements for mental health and substance use disorder clinicians and practitioners. And the other thing is looking at the potential creative use of funding streams. So in some states where there's a lot of money coming into the state for opioid planning, implementation, and treatment, that frees up some other kinds of monies that would allow states to do more creative work around additional layers that prevent people from accessing care. When we talk about task forces, we're also talking about making sure that the DV field is actively participating on state opioid task forces. Next slide, please. So again, this is just kind of an overview. It's pretty common sense, thinking about what are the things that we can all do to engage partners across fields at the state level and at the community level. And I think we've heard some wonderful examples of that today. To identify the needs, resources, barriers, and opportunities. And I was really struck, Regina, when you talked about state-level data, and we have found that too. And I think a number of the states we've talked about how important that is and what strategies can be put in place to actually collect that data in safe ways. What kinds of things support integrated services, and that means thinking about both state and federal funding. Thinking about the additional system-related barriers when, one state talked about how reporting requirements, I think it was in Colorado, for women who are using substances when they're pregnant were changed so that you could report to a behavioral health provider and not just to a healthcare provider, and that information was more protected so that people were more likely to access services. And the other key thing that we want to emphasize is, and that all of our informants have highlighted, is involving people with lived experience at each point of the process in leadership roles, and ensuring that services are not only accessible and trauma-informed, but also culturally responsive. Next slide, please. So again, this is just saying that optimally serving individuals, children, and family who are impacted by domestic violence and many other forms of lifetime trauma requires that we all work together in order to address these unique and complex issues. Next slide. So I will turn this over to you, Kenya. Do you want to close?
Sure. Thank you so much, Carol, and to all of our presenters for everything that you've shared today. I know there were a couple of questions in the chat, so I do want to leave at least a couple of minutes to get to those. But I really just appreciate the rich examples that were shared and the depth of knowledge and perspective and experience that has been gained from the National Center's work on this. And I agree with something that Dr. Warshaw said, is that some of this is pretty common sense, that we really want to work within the spirit of providing the best services and supports to enhance survivor safety as well as that of their children. And as much as possible, we want to be able to provide those services where we keep children together with their parents while they're seeking services as much as possible. So please continue to be in touch with the National Center, but also be in touch with us here at SAMHSA and at the PHPSA program to share with us what concerns you have, where you're making strides and successes, and what additional technical assistance might be helpful to you within your states and your communities, because we want to continue to build a knowledge base around a lot of these issues. So with that, I just want to thank everyone for joining the webinar, webinar, and I'm going to pass it over to Gabriella to hopefully respond to a couple of questions that were posted in the chat and maybe share a few resources that are remaining. So thank you all for joining today.
Great, thank you, Kenya. And it looks like the questions that have come through the chat were actually answered kind of as they were entered. So right now, I'll go ahead and just share some of our different resources. Here is our contact information for Carol and I here at the center. Please feel free to reach out to us. And then some additional resources with different national resource centers and technical assistance resources, national domestic violence hotlines, resources on children who are exposed to domestic violence, online learning and toolkits, and then our page specific to mental health and substance use treatment and recovery support providers. And with that, we have run out of time. Thank you, everyone, for today's webinar, and thank you to Carla for making the webinar run smoothly. Last but not least, thank you all for spending your time with the center. Within the next week, we will send you all a follow-up email with a link to the recording of today's webinar, in addition to the slides and handouts referenced, all of which will be available on our website. You will also receive a certificate of attendance for your time today. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, it would be greatly appreciated. Thanks again, and we hope you have a wonderful day.